Hello, and welcome again to the Surgical Oncology Clinics podcast. Surgical Oncology Clinics is a quarterly publication from Elsevier consisting of review articles centered on a major topic important to surgical oncologists. I'm John Vassallo, managing editor of the series, and for our fifth podcast, we'll be discussing the April 2022 issue devoted to colorectal cancer. In the United States, more than 100,000 new cases of colon cancer are diagnosed on an annual basis, and more than 53,000 people will die this year from this insidious disease. Also, while the annual rates of colorectal cancer have declined since the late 2000s, rates of colorectal cancer among younger adults have increased. Here to discuss why this is, as well as other articles in the issue, will be our consulting editor, Dr. Tim Pollack, professor and chair of the Department of Surgery at The Ohio State University Wexner Medical Center in Columbus, Ohio. Joining him will be the guest editor of the colorectal cancer issue, Dr. Tracy Hedrick, associate professor of surgery and chief of the Division of General Surgery at University of Virginia Health in Charlottesville, Virginia. Welcome to both of you, and over to you, Dr. Pollack.
Thanks, John. Really appreciate that introduction. I'm super excited to be with Dr. Hedrick today, who did a wonderful and masterful job guest editing the latest volume of Surgical Oncology Clinics. Really put together a wonderful group of co-authors to bring us up to date on the state-of-the-art management of colorectal cancer. You know, Tracy, I really couldn't think of a more important topic. Colon cancer is so prevalent in the United States and worldwide, and I just really want to commend you for your excellent leadership of this volume. So thank you very much. Was going to start off with one of the first articles that we're going to discuss, early onset colorectal cancer. And this was by Dr. Vij and colleagues. And, you know, as we heard to run into the podcast, early onset colorectal cancer has been something of an increasing topic of interest as of late. You know, traditionally we think of cancer being associated with age and older people getting cancer, but there definitely has been this increasing phenomena of individuals presenting with colon cancer in their 40s and 50s. And I was wondering if you could share with us a little bit about your thoughts around early onset colorectal cancer and how it may represent a different kind of epidemiology and even underlying biology of disease that we should be aware of as cancer providers.
Yes, well, first of all, I just want to thank you for this opportunity. It was really a great experience working with all these co-authors, and you know, they just did a fantastic job. This chapter in particular, very informative. You know, it's something we're seeing more and more of. The youngest patient that I have seen has been 18, had a huge rectal polyp, you know, completely sporadic. And so, you know, it's something that if you're practicing enough, you are going to see over and over. And it does seem to be a different type of cancer. So compared to the older population, there is much more prevalence of left-sided cancers and rectal cancers in the younger population. They tend to be diagnosed at a higher stage because, you know, obviously people aren't thinking of cancer in such a young population. And, you know, they do seem to have underlying different biologies. There's higher rates of MASH6 mutations. The cancers have been shown to lack BRAF mutation, and therefore BRAF targeted treatments may not have as much of a benefit. You know, when you look at the outcomes stage for stage, the younger patients do tend to do better owing to the fact that they are healthier, but at the same time, you know, they tend to be diagnosed later. So it's a very interesting field of study. Obviously, a lot of research is being devoted to try to figure out why this is the case. There are a lot of theories out there, and certainly a lot of opportunities for future research. Processed meats, red meats, have been implicated as a possible etiology. There are data to suggest that calcium can be a protective factor, and fiber seems to play a role in calcium absorption, as described by the authors. Alcohol consumption and sugary drinks obviously tend to increase the risk, just as in older patients. And then there's been some research about antibiotic exposure. That data is mixed, but another interesting field of future research.
Yeah, that's great. I think it's important to clarify for the listeners that we're specifically talking now about sporadic early onset colorectal cancer. And I was wondering if maybe you could comment a little bit more on, hereditary colorectal cancer and the distinction we're making here with sporadic early onset colorectal cancer. And then maybe chat about that in light of the new American Cancer Society recommendations around screening for colorectal cancer.
Right. So, obviously the patients that have hereditary syndrome, such as Lynch or FAP, are at significantly increased risk of the development of early onset colorectal cancer. But when you look at it as a population, that really is only the case in about 15% of those that are diagnosed before the age of 40 to 45. And so really what is so alarming is the increase in the sporadic cases. And that finding has led to the reduction in the age of screening from 50 to 45 years of age, to try to capture some of these that are developed at an earlier age. As I mentioned, the majority of the cancers are on the left-hand side. So there's even thought that the use of flexible sigmoidoscopy as opposed to colonoscopy could be used as a fairly effective screening strategy in the future for younger patients, certainly that present with bleeding.
And then what about any kind of epidemiologic and or racial, ethnic disparities when it comes to early onset colorectal cancer? Are there any data about the incidence of early onset colorectal cancer among non-Hispanic whites, perhaps relative to non-Hispanic Blacks or Hispanic patients?
Yeah, so, as is the case in the older population, there are significant disparities, so higher incidence rates in Black and Hispanic patients. There's also geographic differences. There's a higher rate of early onset colorectal cancer sporadic in the South compared with the West or the Midwest. And, social economic disadvantage has also been associated with higher risk of the development.
That's very interesting. So kind of making a transition onto the next paper by Dr. Perez and colleagues. This is an interesting topic and one that I can remember even when I was a fellow many years ago. It was beginning just to emerge and was hotly debated. And this is the topic of watch and wait strategy for non-operative management of rectal cancer. And so I was wondering if you could start off by just telling us a little bit, who might be candidates for the watch and wait strategy, and how do you think about this when you're seeing a patient who has rectal cancer?
Yeah, so this is obviously one of the most relevant topics in colorectal cancer today. I'm actually in Tampa at our annual American Society of Colon and Rectal Surgeons meeting, and this is at the forefront of many sessions. It evolved out of patients facing the decision of having a permanent colostomy in the setting of achieving a complete clinical response to neoadjuvant therapy. Many of those patients, do not want a permanent colostomy. And so much of this data started in Brazil with retrospective studies of following these patients along and demonstrating in patients that were able to achieve a complete clinical response, they could achieve durable results from this. And so it really started with that patient's population, very low tumors that would require an APR for excision. Certainly those that could be palpated on a digital exam. And since that time, however, it has expanded into slightly higher tumors, but the physical exam findings are a very important part of the surveillance strategies in this population.
And then can you tell us a little bit more about what type of response might one need to see that would help identify who are the best candidates for this approach? Is there a certain number of rounds of therapy? Do they need to have a very good response initially? And then how does one assess the response? I imagine it's through cross-sectional imaging and also endoscopy. But how would a clinician assess someone who's had a good response, and then you could feel comfortable watching and waiting?
Right. So there are very clear signs of a complete response. What you really want to see is a nice pearly white, completely soft scar that's got telangiectasias. And the chapter actually has very good pictures of what is and is not a complete response. There's something that's called a near complete response, where there's still a little nodularity of the scar. And those are the patients that you have to worry about. If it's very early on in their treatment, just after completion of radiation, for instance, you can give those patients a bit more time to see if they reach that complete response. But you really are looking for a completely white, soft scar with telangiectasias. And there are different regimens. There was actually a large trial that was just published by Julio Garcia Aguilar and colleagues, a multi-center prospective trial in the Journal of Clinical Oncology. And these were stage 2 and 3 rectal cancer patients that were randomized to 2 different regimens, either induction chemotherapy followed by chemoradiotherapy, or chemoradiotherapy followed by consolidation chemotherapy. And then they were assessed for the complete clinical response rate and then for regrowth. And that trial was very interesting in that it has demonstrated that there's a higher rate of regrowth with induction chemotherapy followed by chemoradiation, as opposed to chemoradiation followed by consolidation therapy. So that trial will be very important going forward in assessing how best to do this.
And then what about the surveillance of these patients? If someone has had, a so-called complete response, how do you counsel patients with regards to the intensity and type of surveillance that they will need? And then also, how do you counsel patients with regards to their anticipated outcomes? What's the chance that something may indeed regrow after it initially being designated a complete response? And does this approach perhaps adversely impact patients' long-term survival?
Yeah, so this involves very intensive surveillance. So the patients, certainly in the first 2 to 3 years after completion of therapy, need to be seen and examined every 3 months with a digital rectal exam and a flexible endoscopy. In addition to that, we do cross-sectional imaging generally every 6 months to look for lymph node recurrences that might not be picked up on flexible endoscopy and exam, although 90% can be picked up on exam and flexible endoscopy. The regrowth rate varies according to what you're looking at, but is somewhere between about 25 to 40%. The majority of that is in the first 2 years after therapy. So once you get 2 to 3 years out for therapy, the rate of regrowth is much less. And what has been shown in this most recent trial, as well as the research from Brazil, is that it doesn't seem to affect long-term disease-free survival if the patients undergo resection right away or when they are picked up as having developed regrowth. on surveillance. But they have to be committed to the surveillance. So, that has to be taken into account when a patient is offered this. They have to be reliable.
That's an excellent point. So changing tracks a little bit, we've been talking about kind of, if you will, the ultimate minimally invasive approach, which is watch and wait strategy. And now I'd like to pivot to a more invasive strategy, which is surgical resection. And what should be the extent of that surgical resection when you are treating patients with rectal cancer? And I think the article by Dr. Yu and colleagues did a very nice job discussing this concept of not only complete mesocolic excision, but also this notion of central vascular ligation, and then trying to address the topic of extent of lymphadenectomy, which has been well published in the gastric literature and has been gaining increased attention with the rectal cancer literature. So I guess if you could maybe talk to us a little bit about your take on modern oncologic principles for surgery of colon and rectal cancer vis-a-vis the mesocolon and the central vascular structures.
Sure. So, it's long been known that dissection along the embryologic plane in rectal cancer is very important. And clear data that demonstrates an association between local recurrence survival and violation of that embryologic plane. And so that concept has been explored, particularly in Asia, with regard to colon cancer, where that type of dissection has not traditionally, in the US at least, been felt to be quite as important. So Dr. Yu and her co-author in this chapter, who has extensive experience in this technique, having trained in Tokyo and now come over to practice at MD Anderson, really do a great job of outlining the technical aspects of the complete mesocolic excision for colon cancer, namely right-sided resections, but also the extent of the lymphadenectomy. And, it is a controversial topic. With regard to colon cancer, the trials are mainly retrospective. There are a couple ongoing prospective trials that I think will provide some insight, but this is very much a topic that's hotly debated.
Yeah, so speaking of hotly debated topics, I was wondering if you could expound a little bit on the extent of the lymphadenectomy and this notion of a D3 lymphadenectomy that would include the pericolic, the intermediate, and central lymph nodes. Do you believe that a D3 lymphadenectomy is required and should be the standard of care? Do you think there's a survival benefit associated with the D3 resection, or do you think it is just a more adequate staging procedure?
Yeah, that's a great question. And I think one of the things this chapter really did a great job at was describing the nomenclature. So they used in this chapter central vein or central vascular ligation and the D3 dissection. And the biggest difference, as they described between these two techniques in right-sided and transverse colon cancers, was preservation of the middle colic artery. But, basically involves taking the ileocolic and the middle colic all the way back to the SMA. And, I think there's no doubt that definitely improves the staging of it. There are between 1% and 3% of patients that have lymph nodes that high along the chain. And actually, even the recommendation on the left-sided resections, the rectal resections, there's not clear evidence that suggests taking the IMA right off the aorta improves survival. a lymph node at that location is almost certainly associated, with worse prognosis. So that really is what, a lot of the critics say, is this is just offering better staging. When you look at a lot of these different trials that were described in this chapter, there are very significant differences in the administration of adjuvant chemotherapy. And, that confounds the results. I really do think we need prospective data on this to really answer that question.
And then one other topic that was touched on in this chapter, and then to segue to the final chapter that we'll be talking about today by Dr. Silla and colleagues on technological advances in the surgical treatment of colorectal cancer, is that we've been talking about, the extent of resection, the extent of lymphadenectomy, high ligation of vessels. And as we move more and more towards minimally invasive approaches, whether they be laparoscopic and or robotic, I was wondering if you might comment on the role of minimally invasive surgery, both from the perspective of short-term perioperative outcomes, as well as oncologic outcomes, both pathologic outcomes such as lymph node harvest, circumferential resection margin, but then also long-term survival.
Yes. So, again, another really fascinating topic. And particularly this topic is where it's really important to separate the colon from the rectal cancer. So with regard to colon cancer, there's lots of data starting most importantly with the COST trial that demonstrate improved short-term outcomes with minimally invasive surgery and no difference in long-term outcomes. That of course excludes patients that have large locally advanced cancers that may require multivisceral resections or things of that nature. But in rectal cancer, it's a bit more muddy. So there have been several prospective randomized trials looking at minimally invasive surgery, including both laparoscopy and robotics, with regard to short-term as well as long-term outcomes. And what I find very interesting is that there is not near the advantage in short-term outcomes with rectal cancer in a minimally invasive approach. And I think that's because a lot of the morbidity of surgery for rectal cancer has to do with dehydration from having a new ileostomy. It has to do with anastomotic leak. Those risks are the same virtually no matter what the approach. The hottest topic, though, are the pathologic outcomes. Two of the trials, ACOSOG Z6051 and the a la carte trial, failed to meet criteria for non-inferiority with regard to the pathologic outcomes. Now, both of those trials, there was no difference in at least the 2-year disease-free survival. And the other trials mentioned in the chapter, no differences in long-term oncologic outcomes, but we're still awaiting the 5-year data on those. So the other technique to mention is transanal TME, which is described as a bottom-up approach. That is a procedure that evolved out of transanal endoscopic surgery, where the majority of the dissection is done transanally. That is a technique that has been around 5-7 years or so, and still in the process of collecting prospective clinical trials on that. And that really is a technique that Dr. Silla, who is the main author of this chapter, really was a crucial pioneer for. So a great chapter and a review of all that data.
One topic that Dr. Silla and colleagues touched on at the end of the chapter was this notion of functional outcomes. And I was wondering if you could touch on that. In particular, there was some discussion around, for rectal cancer, robotic versus laparoscopic versus open, and different functional outcomes, specifically around urogenital function. And I was wondering if you could comment on that and just the role of the robot in general for rectal cancer.
Yeah, so functional outcomes is, critically important with regard to rectal cancer. Urogenital function, in addition to bowel function, which can really have a crucial impact on quality of life. And, several of the trials described are now producing their long-term outcomes, which have demonstrated, not significant impact on long-term quality of life. One of the things with the transanal TME that was shown early on was a higher rate of urethral injuries. And that's because the technique is very challenging. And, I went to a course early on and there were 5 experienced colorectal surgeons that were learning the technique. And of those 5 experienced colorectal surgeons, 3 got into the urethra on the animal model. So it's a really difficult technique. That's one of the known complications that make the training and implementation of this technique of critical importance. And Dr. Silla and her colleagues are working on national training modules to try to effectively adapt this technique into practice.
Well, Dr. Hedrick, I want to thank you again for spending time with us today on this podcast. You've done a masterful job in assembling this volume of surgical oncology's clinics, and really have taken us through in the volume the epidemiology, the pathogenesis, molecular underpinnings of the disease, as well as help the readers better understand the current state-of-the-art treatment, both from a surgical, medical oncology, radiation oncology, and diagnostic imaging point of view. So, this will truly serve as a wonderful resource for the practicing surgeon, as well as trainees who want to be fully up to date on the treatment of patients with colorectal cancer. So once again, I applaud you, Dr. Hedrick, and all of your co-authors and colleagues for your work on surgical oncology clinics. So again, my sincere gratitude and thanks. And we look forward to your further contributions to the field.
Thank you so much.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to the April 2022 issue on colorectal cancer, Volume 31, Number 2. The series is available for individual print subscription with online access or individual online-only access. Visit www.surgonc.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Amazon Music, Spotify, or Stitcher. Thanks for listening.